Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hi, everyone, and welcome back to the Skin Sync podcast. This is Buchi, Neita, and I'm very excited to be back today with Lisa Weiss, my co-host. Lisa, let's talk about hair loss today. When we were discussing topics for this episode and we touched on hair loss, you really perked up. You got excited about it. So tell me why that is, because I think most people would have the opposite reaction.
You know, I think hair loss is something that sometimes you do have that like, oh, another hair loss patient coming into clinic. But I think I perked up when we were talking about possibly doing hair loss because I'm a hair loss patient myself. And I think that there's a lot of hair loss that's misunderstood in the derm world. And there are new advancements in the hair loss space. And it makes treating a hair loss patient more exciting because I have more I can do for them. So I think that's why I lit up. I think you're a great person to talk about hair loss with, and I'm excited to dive deep and talk about some clinical pearls we can give to people.
Absolutely. I think for me, it was never an interest, to be completely honest. When I started practicing years ago, if anything, I would slightly, I didn't want it because we knew that hair loss visits, generally speaking, especially for women, would be longer visits. Oftentimes they can get very emotional and, we didn't have a lot of great treatments. And even now we still struggle to find the best options. So it wasn't something I really loved treating. However, as I've gotten better at it over the years and really honed in on my clinical skills and learned how to really treat effectively, I actually enjoy treating it now. And I think when patients have success, they refer everybody to you. So now you're the hair loss expert in your clinic, right?
Not ready to be quite that type of expert. And I don't want everybody sending all hair loss to me, but I do really like being a resource for the other APPs in my practice and really being an asset to my patients and helping them understand that having hair loss is not like a death sentence. It's something that we really can help them with. So I always feel like if I can give anybody even just one great pearl for their own life or for their patients' lives when it comes to hair loss, it's something I really enjoy doing.
Absolutely. So, what we're going to do is kind of break this up into a little three-part series where today we're going to go over just the details when it comes to taking a history, doing a good clinical exam, what clues to look for, what labs to order. And then we'll also discuss later non-scarring alopecias, and then we'll get into scarring alopecias at another time. So let's talk about that initial visit, right? So I'm actually going to start with this. When you have a patient that comes in for hair loss, maybe they're there for a full skin exam and they casually mention, "Oh, by the way, I have hair loss." What's your approach to that visit? Do you try to address it all at one time? Do you have them come back for maybe a more detailed hair loss only visit? What do you do?
You know, I think that's a really important thing to address before you even start talking about hair loss because it really is something that you really do have to distinguish. Is there time in this visit to give hair loss the time that it really needs to discuss? If I know a woman has just had a baby or lost 40 pounds or had some major stressor in her life, I might have a conversation about hair loss during that visit because it's something that I know that I can address, fully manage, and move forward and give it the time it deserves. If I don't think it's that quick type of hair loss visit, then I really do sit down and I look at the patient and say, I love discussing hair loss and I want to talk about this with you. But hair loss really requires its own visit because I want to give you that deep dive that you deserve so that we make sure we have the correct diagnosis and the correct treatment algorithm to make sure you get the best results you possibly can for your hair loss. And I explain the importance of that. Sometimes, if I think that a biopsy will be helpful, I will do the biopsy during that initial visit because then I have the results to the biopsy and we can discuss it during their further hair loss visit. How do
Yeah.
you do it?
I think I take the same approach. I would say probably more often than not, though, I ask them to come back because even when you think it's going to be a brief conversation or a quick reassuring, you have telogen effluvium and you'll be fine, it often ends up being a more extended visit than that. And so I will usually kind of take that same approach where I ask the patient to come back. I'll find some space on my schedule within that next week or the week after to work them in. And I think they're pretty receptive to that. I don't get a lot of pushback when I tell them, like, listen, hair loss can be really detailed. I want to make sure that we have time to review your history. If you've had any lab work recently, bring a copy of that with you or pull it up on your phone and take screenshots. So I give them an opportunity to really get prepared for it. And especially for Black women, with any woman too, but especially with Black women who tend to wear either hair extensions. Sometimes they'll have wigs that are either sewn down or glued down. Sometimes they have braids in their hair. I want those things out. I can't do a proper exam without thoroughly evaluating your scalp, and I don't want patients to expect me to do that because I'm really not doing you any justice by doing that. So I have them come back. We can plan it around your hair appointment schedule, and I want to see your hair as is in its natural state. So I think patients are receptive if you give them the reasons why that visit needs to be detailed.
Agree with you. I always stress them. I'm like, this has nothing to do with a copay. This is really because I want to deep dive into what we need to talk about with hair loss. And if it's just added on to your skin check, you can't do that deep dive that you really want to do.
Exactly. So let's say we're there at that hair loss appointment now. We're starting the history, right? Because that's probably one of the most critical things we can do for a hair loss visit. So what are the questions that you're asking when it comes to that history, that medical history?
I mean, biggest thing, how long has this been going on for? Like, anybody else in your family have any type of hair loss that you've noticed? What type of styling trends have you had done? Like, any changes in your diet, any major stressors in your life? Those are big questions that I ask first. Anything I'm missing that are your big questions that lead off the conversation?
No, I think you mentioned this earlier too about the weight loss, but I think in the era now of GLP-1s, where patients oftentimes are losing massive amounts of weight in very short periods of time, that weight loss history is really important. And not just the weight loss, maybe their weight loss has been a bit more steady and gradual, but their nutrition, like what are you eating? Are you eating more than one meal a day? What does that meal consist of? Oftentimes with these GLPs, patients just have no appetite. They don't want to eat or they have no desire to eat. And that's obviously going to impact their hair growth, potentially their iron levels and everything else. So I think that question's really, really important. You may have mentioned this already, but the psychosocial history, right? What are those stressors going on in your life? Whether they're, a divorce, a breakup, or just chronic stress. If you're just, I think most of us are dealing with this every day, but just that low grade chronic stress, sometimes your body just breaks down and it manifests in hair loss. So I think that those questions are really important. I have a question for you, actually. You mentioned family history. When it comes to hair loss, which particular hair loss conditions is that relevant for you? Like, which conditions are you seeing where that family history is really important?
I mean, androgenetic alopecia, I think, has a huge family component. Obviously, there's a genetic component to this. Um, I feel comfortable sharing this on the podcast, but I'm an androgenetic alopecia patient myself. And it does not run on my mother's side of the family. It runs on my father's side of the family, but it really runs in the women on my father's side of the family. And there aren't that many women who are actual, like, not married into the family women. So it took kind of really tracing pictures back in my dad's family to realize that it came from specific women in his family. So I always ask about for androgenetic alopecia, I always ask anybody in your family on either side of the family that might have a larger part or that feels like their ponytail got smaller as they were getting older, or that they went from feeling like they really had thick strands of hair to they felt like they had thinner hair than they had ever had in the past, because that's what happened to me, and it happened in my very early 20s, which is not necessarily a time frame that you would think that you would see hair loss in a woman.
Right.
So, but it is a time frame that you can see androgenetic alopecia. So it's a big thing for me. I also think with alopecia areata, asking about any sort of autoimmune diseases in the family is a really important thing, because it can run in the it does run in the autoimmune family. So I always ask about family history with alopecia areata as well.
I agree. And as you know already, Dr. Crystal Agu, hair expert from Johns Hopkins, she does beautiful work when it comes to scarring hair loss, especially in Black women. But when it comes to CCCA, there's a lot of evidence showing that there is some family and some genetics involved there. And so you do want to ask if you're seeing a patient where you think there could be CCCA, ask about that family history, and oftentimes you may get a positive there. So a couple other things in that history that I would ask patients, of course, is symptoms, right? Is there burning? Is there itching? Is there stinging? Are you noticing flakes and redness? Sometimes patients will have, concomitant like seborrheic dermatitis, right? So we can't treat one thing without addressing the other. So I think addressing those symptoms is really important. And then again, for hairstyling practices, and this is not just for women with textured hair or for Black women, for all women. Like, what are you doing to your hair? I have women who blow dry every single day. They're running a flat iron through their hair every single day. And, that's going to take its toll after a while, especially depending on your hair's natural integrity. So I think asking about that hair history, the styling history, how often are you cleansing your scalp and washing your hair? But all of those are extremely important. Anything else for you?
Yeah, I mean, I think all of those are incredibly important, and I also think hair coloring practices are important. If you have women that are really bleaching their hair, it can affect that hair integrity as well, and we need to pay attention to those things too. Sometimes women talk about how they think they have hair loss, but it might actually be hair breakage from
Yes.
the over styling of the hair, and it's not actually a root problem.
Yeah, I had this little lady, older woman, just a few weeks back, and for the life of her, she couldn't figure out why her hair is not growing. And I'm like, "Ma'am, your hair is growing. I can see that it's growing. It's just breaking off." It was so dry and so brittle. And as we kind of investigated what she was doing to her hair, it was just complete abuse. Like she was just, again, stripping it dry all the time, not using the right products. And so I actually didn't really offer her any treatments because she was already on minoxidil, interestingly, for her hypertension. So I recommended she get with a hairstylist. I gave her a list of stylists in the area, and hopefully she went. I haven't seen her back yet, but she was an older white woman, and I think it just really hadn't crossed her mind that she was damaging her hair with these, heat straightening products. So just something to keep in mind that patients sometimes are unaware of what they're actually doing and how harmful it could be.
Right. And I think sometimes they choose the wrong trigger in their life. I think sometimes diving deeper in your history and maybe leading questions in a way by you're looking at their scalp pattern, just like you said with that woman and how I feel about the dyeing practices. It's sometimes we have to lead that conversation based on what we're seeing and dive deeper in spots that they might not even think are a pertinent part of the history.
Absolutely. So then moving on to that exam, right? This is I think one of the most critical parts of making that accurate diagnosis and sometimes multiple diagnoses in one session. But what are some of the things that you're looking for in that exam? I know obviously we're looking for the pattern of hair loss, but what are some of the clues that kind of get you, to nail down that diagnosis?
I definitely dermoscopy is a big part of this for me. I use dermoscopy a lot when I'm looking at hair loss. I'm always looking at the distribution pattern of the hair loss. I think that's incredibly helpful when I'm talking about androgenic or androgenetic alopecia, looking at that widening of the part. A lot of times with an androgenetic or androgenic alopecia patient, I can tell immediately when I walk in the room. Like as a patient myself, you immediately see that widening in the central part and you know what you're dealing with, or that bitemporal recession in male or female patients, and you really kind of know what's going on there. If you I look at the front of the scalp when I'm looking at a traction patient, and you can see like if there's that preserved edge, if there's not a preserved edge, looking at those different patterns, the patchy patterns you see with alopecia areata. I always love looking at the different patterns of alopecia areata. The first time I ever saw an ophiasis pattern of alopecia areata, I had read about it in textbooks and I was like, wow, this really looks like that. And so I think looking at the pattern and the distribution is huge. I think looking with your dermatoscope and looking at the different hairs to see the different patterns is a really important part of looking at the diagnosis and using that history with the pattern to really help build your differential of what potentially could be causing the hair loss for a patient. What do you think?
I agree 100%. I think some other things to keep in mind when you're doing this exam is you need to examine it, right? I'm sure you've encountered this, but I have so many patients that have come to see me after having seen other providers, and they said that provider didn't even touch them, like didn't even look through their hair. There was really little to no exam that was done. And we talked about this in one of our early episodes. But it's really getting in there and doing the exam, especially when there's that patient provider disconcordance, when maybe it's a Black patient with a white provider. They really want to know that you know what you're doing, that you know what you're talking about, and that you're comfortable doing an exam. So I think it's important to ask permission first, right? If you can get in there and do an exam. I think wearing gloves is not inappropriate. Some patients have a lot of, milky kind of sticky hair products. So I think it's fine to glove up. If you need to pull out some tools, sometimes I'll use my cotton tip applicator to help me part the scalp. But it's so, 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 so critical for patient satisfaction and also for a thorough exam to really get in there and look at that scalp completely. Like literally, go not strand by strand, but essentially part the hair, take a really good look at the entire scalp so you know what you're dealing with. And another thing I think is important too is looking outside of the scalp, right? We know there's a lot of conditions that manifest in areas that aren't just the scalp. So if you're dealing with discoid lupus, for example, which can cause scarring, hair loss, how about we look inside of the ears, the conchal bowls? Is there any rash in there? If we're dealing with frontal fibrosing alopecia, which we know is increasing rapidly in its prominence, we know that we need to look for facial papules. Some patients will have these little fine facial papules. They'll have loss of their brows, lateral brows. I think we need to look for clues in maybe hyperpigmentation. They may have lichen planus pigmentosis along with that frontal fibrosing. So just looking outside of just the scalp to see if there's anything that can clue you into that diagnosis.
I agree completely. I think something that's really important that you shared with me a long time ago, and you touched on it briefly, is when you are taking care of a patient that is of a different background than you are, stressing to them that you take care of patients of all different backgrounds. When African American women come in and see me, I always stress to them, I know hair loss in all patients and I understand hair from every background. And I'm here to help you and I'm here to treat you. And a big clinical pearl that you gave me, and I do think it makes my African American patients feel more comfortable. I always ask if I can touch their hair. And that's something that you shared with me years ago that I have brought into every single exam room. And I do think it's something important. You want to make sure that the patient knows that you respect their hair and you respect their hair practices and that you don't want to mess anything up that they've had done. I know how much time it takes for an African American female to do their hair. I'm envious of how long you can wear your hair a specific way.
Right.
So
Yeah, I think
I think
that's
those are important things to take into account.
I appreciate you sharing that. I think it's really critical. And it also helps too if you know some of the styles. Like you don't have to know every single style. I don't know all the styles. My MAs were telling me about some new hairstyle called marigold braids that I didn't know about. But I think if you at least learn some of the big ones, locks versus sister locks versus, braids versus knotless braids, straightened hair, relaxed hair, if you just kind of know some of the maybe the top 10 hairstyles, in Black women, which that's going to be hard because there's so many different ones, but I think just knowing the names, understanding the styles, recognizing which ones are potentially high risk when it comes to, traction alopecia, which ones are a bit safer, that's really, really important as well. But I think, we that's a pretty good, we got into how to do a really good exam. Anything else that you're doing with your exam that gives you clues? Anything else that we need to be doing? Are you doing the pull test? Are you doing any other, are you doing biopsies most of the time?
I do a pull test pretty frequently, especially with all this GLP-1 hair loss that we're seeing. I do a pull test and I do see if there is a significant amount of hair that I'm extracting with a pull. Sometimes you can get false results if a patient's washed their hair that morning because they've lost that hair already that may fall out in a pull test. And I never make a patient feel bad if they bring me in a bag of hair. We always wonder what comes in those special bags that patients bring in for you. But when a patient brings in hair, as long as they're not like, this is the hair I've collected over the last 6 months, if they're like, this is the hair I've lost in the last week, I really do take that into account. That if there's a good amount of hair in a bag, like I address with the patient, I see what you're talking about. I see that you have hair loss. I don't want to dismiss it because it's important to them. And I want to make sure that they understand that I am listening. I do care. I know this is a problem. And I always say to them, and especially to women, that 50% of men bald, but 50% of women thin at some point in their life. And so some of this can be a normal process, but let's look further and see if what's going on with you is a normal process or if there's something in here that I can help fix for you. And I think that's a reassuring sentence for them that makes them feel comfortable with me touching their scalp, with me diving deeper to figure out what is the cause, with me pulling on their hair. When somebody's losing hair rapidly and I'm like, I'm just going to go around your head and pull on some pieces and see if it falls out, that can be distressing
Right.
to a patient.
Right.
So once I say things like that to let them know I do know what I'm doing when it comes to your hair loss, I do think that gives them a little bit more comfort. So I always really try to talk them through every single thing I'm doing when I'm doing a hair appointment because I think it's important that they know why I'm doing certain things.
Right. I agree completely. So, you do your exam, you do your pull test, maybe a biopsy if you're unsure. And what about lab work, right? That's usually the first thing patients will want to jump to, right? They want to get a ton of labs, they want the battery of tests, they want to get screened for autoimmune disorders. But before we go down that path of doing the $1 million workup, what specific tests are you typically ordering, especially in female patients, that can help clue you into their hair loss, or even if it's not the cause, things that can hinder their hair growth, but what are some of the things that you're looking for?
I draw ferritin on a pretty regular basis to make sure ferritin is really in that range to make sure hair is growing. I stress to patients that labs are not the be all, end all, tell all of hair loss, and that even if I figure out that you have a deficiency somewhere, it may not be what's causing your hair loss. And I stress that above everything else because I think so many people are so dependent on this number means I have something. And that number doesn't always mean something. So, thyroid, I think, is the low hanging fruit that if there's something going on with your thyroid and it's something that can be fixed, that we can do something about it. Although I do think a lot of our patients do see their primary care providers on a fairly regular basis and their thyroid numbers tend to be in line. But if they haven't had it drawn in the last 6 to 8 months, sometimes I'll draw thyroid for them. Ferritin is a big one for me. I draw ferritin pretty frequently. And I I draw vitamin D on a lot of my patients, a lot of my psoriasis patients as well. So I'm a big vitamin D checker as well. Anything that you draw?
No, I think that's kind of what I do as well. I'll check a CBC. There are a lot of women, younger women especially, or premenopausal, who are just walking around anemic. They're just walking around iron deficient. They've got terribly low ferritins, and I think they've just had that for so long they don't address it, or maybe their primary care doctor isn't checking it, or maybe it's not as concerning to them. But I think it's pretty rampant, and it just really can't be conducive to growing good, healthy hair, and overall, just their general well-being. So I always check that. Just like you mentioned, vitamin D is pretty typical for me, thyroid test. I don't do a lot of hormonal tests, and I certainly don't do any sort of ANA or autoimmune tests unless there's something else going on that I'm concerned with as far as like a discoid lupus or something along those lines. But I think that's just something that can open up a can of worms by checking an ANA and it ends up being positive, right? Because that's not always relevant.
Correct. I agree. I do the same thing. And I always guide them that when I'm drawing labs for hair, I don't necessarily guarantee that the labs are going to be covered by their insurance. I feel like insurance companies more and more frequently don't love to cover hair biopsies, and they think of hair as a cosmetic problem as much as we all know that it's not. And it's a major part of your identity. I do think sometimes you do have to lay that out for a patient out of the fear that if they get a bill that they get upset with you. I just always mention that there's a possibility that things that we're doing for hair are not going to be covered by insurance.
Agreed. So, Lisa, this was a really great kind of, intro into hair loss, right? How to do that workup, how to ask the right questions, how to do a proper exam. So, this is wonderful. And I can't wait to come back and talk to you more about non scarring alopecia. I'm going to have you share your story about your personal journeys with androgenetic alopecia. And then we'll also talk about scarring alopecia later on. So, thanks everyone for listening. And thank you, Lisa, for being here.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.